Request a young dynamic surgeon from Jaipur, Rahul Upadhyay, who's taking foot and ankle in Rajasthan forward. So Rahul, please, can you share your screen?
Sure, sir. Thank you.
And if there are any questions on, Pilon, you can just jot down Alok so that you have the answers ready for it when we have a session on case discussion section on ankle fractures. Rahul, please.
Sure. Thank you and welcome everyone. So our idea about the ankle fracture is at least we should go back and be able to identify the pattern, injury pattern here, and then apply the principles later on. So once we are done with this lecture, we should be able to identify what kind of injury pattern, what kind of x-rays are there, and how to go ahead from there. So just a brief introduction. It is one of the most common intra-articular fractures of a weight-bearing joint. And the problem is that malunion, it may lead to arthritis, abnormal pressure distribution around the ankle. And there is a lot of study and work has been done by Ramsey and Hamilton over it. So the ultimate goal is to have a congruent joint with a good union and prevention of arthritis. So looking at the basic anatomy, it is a modified hinge joint with 3 bones, tibia, fibula, and talus, but with a complex ligamentous structure. So the movements are in multiple planes. We have a sagittal plane movement, coronal plane movement, and an axial plane movement. So it's not just a uniplanar movement, it is a multiplanar movement around the ankle. That's why it makes it very important to get a perfect anatomical reconstruction once the ankle fractures has occurred. So just have a look at the anterior ankle anatomy where we have ATFL on the lateral side, CFL, and a deltoid ligament from the medial side. This is the deltoid if you look from the medial side. From lateral side, if you look, this is the CFL and AITFL ligaments. And posteriorly, we have posterior tibiofibular and posterior talofibular ligaments. So this is a ligamentous structure around the ankle with syndesmosis. Again, it acts as a joint between tibia and fibula with interosseous ligamentous membrane and ligaments that we talked about. So coming up to the most important part, the classification of the injury and identification of the injury pattern. The idea of having a good classification is that it should be able to explain the fracture pattern, the treatment options that may be needed, and the prognostic expectations of it. We have Lodge-Hansen classification, Tannis-Weber classification, and AO classification. But what we are going to look to today is a combination of this so that we can better understand each classification together. So the Lodge-Hansen classification, it worked basically on the position of the foot and the direction of force which is acting on that particular position. So we can have a supination and a pronated foot, and the direction of force can be abduction, adduction, or the rotational forces. So if you look at this diagram, this is very important to understand what exactly is the position of the foot. So on the left side, we have a pronated foot. Now, if you see in a pronated foot, the taut part or the straightened or toughened up part is the medial part, whereas on a supinated foot, the lateral side of the foot is taut. So for a taut part to fail, the only force which can make it fail is an abduction of the horizontal force. Whereas in a supinated foot, the only force which can fail this taut lateral part is an adduction force. So it makes it very clear that in a supinated foot, the only horizontal plane movement that is going to further add on to the injury is an adduction injury. So we have in a Lodge-Hansen classification a part known as supination adduction injury. Similarly, in a pronated foot, we had a pronation abduction injury. Rotational injury, of course, are going to be an important part in both the position of the foot. So Dennis Weber, he came up with a classification based on the level of fibular fracture, making it a infrasyndesmotic, transsyndesmotic, and suprasyndesmotic type. So now let's try to identify each fracture pattern on a combined basis. So on the left side, we have kind of a Dennis Weber. And we have combined these two classification systems and we are trying to understand this. So this is a type A or an infrasyndesmotic type of injury, which is kind of a supination adduction kind of injury. So since we saw the supinated foot was a taut foot on the lateral aspect. So the kind of injury or the force that requires to further aggravate the injury is an adduction force. So when we have an adduction force, there is a failure on the lateral side leading to a fibular fracture. And if the force continues, the talus shifts medially, goes and hits on the medial malleus, causing a shearing fracture of the medial malleus. So this is stage 1 supination adduction, and this is stage 2 supination adduction. So this is the sequence of morphological events that happens. So there is failure on the lateral side because of the adduction forces. The talus moves, tilts towards the medial side, hits the medial malleus, causing a fracture. This is the type B injury or a transsyndesmotic injury, where the level of injury is at the level of syndesmosis, and most common force to cause this is an external rotation force. So we have both the injuries in a supinated and pronated foot. We can have these injuries. So talking about the supinated foot, again, as we were learning before that it was a taut lateral structure. So the force starts on the lateral. It's an external rotation force. So it goes from anterior to posterior and comes back and ends medially. So if we see, we have a failure of the anterior of the ATFL ligament. But later on, if the force continues, causes a fibular fracture. If the force goes posteriorly, it may cause a posterior malleolus fracture, and it ends medially, leading to the medial malleolus eversion at the end. So this is how the supination external rotation force occurs. So if we see the morphological events of these type of injury, again, it starts laterally. There is a failure of the lateral structure. The force again continues posteriorly. There is a failure of the posterior structure, and finally it ends medially, leading to the medial malleolus fracture. In the type C or the suprasyndesmotic injury, it is a pronation kind of injury with external rotation forces. Now it is very clear and very easy to understand that any fibular fracture which is suprasyndesmotic is, for a record, going to be a pronation external rotation kind of injury. So whenever you are having an X-ray, even for your exam, if you have an X-ray and someone is asking you the kind of injury pattern, look at the fibula, look at the level of fracture at the fibula. If it is higher above the syndesmosis, it is going to be a pronation kind of injury. And again, the force of direction of the force is going to be the same. If you see the morphological sequence, the first failure is on the medial side, as it was a pronated foot. The force of injuries goes anteriorly, finishes laterally, and if it is type 4, it finishes posteriorly, leading to a posterior malleolus fracture. Radiology, we will not talk much about it because Dr. Girish has wonderfully covered all the aspects of the ankle radiology. So these are the common views: AP, lateral, mortise, and oblique views. Additional views, you might need a full length view just to make sure there is no Massonnev injury pattern, which is a pronation external rotation type of injury. Important radiological indices that we were talking: talocrural angle, medial clear space, talar tilt. We have had a good discussion already over these topics. Just to give you an example how to see. So on the left side, on the right side, we have two X-rays. If you see, this is the left X-ray, is a normal X-ray. The Shenton's arc here, it is quite well maintained. The fibular spike is at the level of the joint line. The medial and clear space and the lateral clear space is good. But on the right side, if you see, there is increase in the medial clear space. The Shenton's arc is broken here. The fibular spike has gone proximally. So the fibula is proximally migrated. So this is an abnormal X-ray. That is how we are supposed to identify some injury pattern for a classification, for example. So this is a type C injury pattern where the force started medially. And now when we take a long leg X-ray, we see there is a proximal fibular fractures. Again, one more example of a supination aggression type 2 injury where we had a lateral failure and tail is tilted further medially, causes a shearing fracture of the medial malleolus. So coming up to the concepts of the treatment, we have to have anatomical reduction, early mobilization, soft tissue consideration, of course, with the swelling, hematoma, necrosis, open injuries or not. And once you have identified everything, your aim is to have an early mobilization. If there is a dislocation, of course, you have to do an early reduction of it. Operative versus non-operative, get the best anatomical reconstruction. That's the idea. If you can do it by non-operative, achieve it, provided the fracture pattern is stable. Unstable fracture pattern, it needs to be an operative management. So it has to be understood like a ring, and it is like pelvis has a ring concept, ankle also works on a ring concept. A ring is stable as long as one part of the ring is broken. But when we have a two-part fracture on a ring, it is going to be an unstable fracture pattern.
2 more minutes, Rahul.
Sure, sir. Timing of surgery, dislocations to be reduced urgent. Otherwise, look for the soft tissue. Consider all other implications like clean wounds, abrasions are there or not. Make sure there is no risk factors for a risky surgery. Adequate pre-op planning, CT scan if needed, and template all the fractures. So these are the some examples where you have to be very clear about your incision sites, when to go for surgery. You want to wait for the soft tissue to be better and then go ahead with the surgery. Do a good pre-operative templating and try to apply this templating exactly as you have done pre-operatively on the table in the operation theater. Anteromedial, anterolateral, various approaches are there, but the sequence of fixation, whatever approach is there, it has to be first a reduction of the fibula. Provisional, definitive, it depends on how you achieve the length, the rotation, and once you have done that, make sure that medially everything is stable, deltoid osteochondral fragments are not there, and then do the definitive fixation. So for a type A kind of fracture, stable fracture, you can manage by cast. Non-stable fracture, you have to plate. Just an example, it was an unstable fracture where we had done a fibula plating with a compression screws on the medial malleus. An example of the same. Trans B or a transendosmotic type of fracture, it is oblique fibula fracture. This is the force for the reduction where you have to have gentle traction and internal rotation and fix with a fibula plate, and if needed, a medial malleus TBW or a plate. This is how you do a plate molding. Again, you know there is an external rotation force, so plate has to counter that external rotation force. So the tip of the plate can be rotated externally. You can make a hook out of it if you want to cut it. So this is how a molded plate looks like. And type C, approach the fibula first, good ligamentotexis, length and rotation, and finally do the definitive fixation. A word about the syndesmotic fixation injuries. Obvious diastasis with suprasyndesmotic fracture needs fixation. Any bimalleolar fracture within 3.5 to 4.5 centimeter of ankle joint. After anatomical reduction, look for the syndesmosis by a cotton stress intraoperatively. If it is stable, don't need. If it is not stable, fix it. So this is the cotton stress. After you fix fibula anatomical reduction, if there is no movement, it is a stable syndesmosis, no need to fix. Screw placement, it is going to be posterior to anterior, about 30 degrees of angulation has to be there for the correct placement. If it is this C, it's an incorrect screw placement where syndesmosis is still open. So you take it out, screw out, place it correctly, and then achieve the correct syndesmotic length. So take home is identify the fracture pattern, take all necessary radiographs and CT scans, then decide the plan of action and achieve a congruent joint, full range of movement and early mobilization for the best outcome of the patient. Thank you.
Thank you, Rahul, for your wonderful talk.